It is my pleasure to introduce Dr. Mary Charles Haigler. Dr. Haigler provides conservative and minimally invasive care for orofacial pain patients at the Carolinas Center for Oral and Facial Surgery. Dr. Haigler is co-director of the clinical rotation in orofacial pain for the Medical University of South Carolina, and she is a presenter for the general practice residency at Prisma Health, as well as speaking at many other continuing education programs. She enjoys speaking on the topics of orofacial pain and TMD, and you're going to enjoy hearing from her. So please welcome Dr. Haigler.
So let's move on to the joint. So they already kind of went over a little bit of the anatomy, but just as a refresher, we're looking at the glenoid fossa. So this is the coronal view, just to kind of remind you where you are. Coronal looking straight at you, sagittal looking from the side. So the fossa is at the base of the skull. It's, of course, nice and rounded in most people. Looking from the sagittal view, you notice the eminence come down. So that guides you in your opening. As you translate forward, as they were mentioning before, the condyle goes down the eminence, and that helps you get your range of motion. What I was mentioning before is the disc here, and some people call it a meniscus. It doesn't bother me, whichever one you want to call it, disc or meniscus, but the little fibrous cartilage here is actually held in place to the condyle on the medial and lateral. So when you're opening, if we imagine this being the condyle and this being the disc, and you all are looking in a sagittal view, okay? So I'm going to hinge first, and I'm going to kind of hinge underneath that disc. Or even if I'm moving towards my right side, then my right condyle is going to kind of rotate in that underneath that disc, okay? Now, if I'm going to translate, opening all the way, or if I'm moving my jaw towards the left, now my right condyle has to go down the eminence. So that's translation. And the disc goes with it for translation, okay? So hinge under, translation goes with it. Now, if those little ligaments get stretched, then that's when that disc can kind of fall out of place. And if it's out of place, then that's where you're hinging, possibly behind it. So a lot of people can still get to their 20, 25 millimeters, but if they try to go beyond that, some people get stuck because that disc is now in front of, or they'll go click onto the disc and then keep going. Does that make sense? Okay, so that is the basic anatomy of the joint and how it functions. So in the temporomandibular joint, it's actually the only movable joint in the body that is connected on either side. So you can't move your left condyle without moving your right condyle. Because even if you're going towards the right side, that right condyle has to move a little bit, okay? So that's a difference. Of course, it's fibrous cartilage instead of hyaline cartilage, and it's limited in one direction by tooth contact. So you can't hyperextend in the closed direction. And then the two compartments are made by what's underneath that disc and what's above the disc, okay? Now to keep going, the articular eminence is anterior. There's a lateral tubercle on the lateral side where ligaments attach. Medially, there's a wall there. Posteriorly, there's a posterior protuberance, but that's also where the retrodiscal tissue is. Now, running through the fossa is a reason why a lot of people will have associated ear symptoms. There's a little fissure there where the anterior malleolar ligament and chorda tympani pass through. So because there's that little area there, sometimes there can be associated ear symptoms. Now, that does not mean that everybody that has a congested ear feeling or a tinnitus has a TMJ problem, but it can be related in some people. So the condyle in a healthy joint is an elliptical shape. It's about 1.5 centimeters to 2 centimeters wide and about half that in anterior posterior direction. It should be nice and rounded. And as I mentioned before, the lateral and medial are where the disc actually kind of holds on. And this kind of shows you a little bit more about the disc, which he was showing you before. It's biconcave. The image right here doesn't show you quite as well that it can be a little thicker on the sides as well. But basically think about a donut without the hole punched out in the middle. So it kind of sits on top of the condyle with little ridges around it to kind of help it stay in place. So looking at an actual cadaver, you can see, now these are distended. They're kind of down. They're not up in the fossa, but you can see how the disc is thicker in the posterior, thinner in the middle, thicker in the anterior. You can also see this is the lateral pterygoid coming in, and all of this back here is the retrodiscal tissue. So again, a lot of nerves, the blood vessels. That's why it can be sensitive when the disc is out of place and you're impinging on that tissue, okay? That's just more about the measurements of the disc. So you can see the difference is about a millimeter between the anterior and the middle portion, just a millimeter thicker. And in the posterior, it's about 2.7 millimeters thick, so about 1.5 millimeters-ish thicker. So it's not a dramatic difference, but it's enough to help it to stay. So these are the problems that can happen with the disc. Basically, in a healthy joint, as we have at the top, as you open and you translate, the disc stays right between the condyle and the eminence, okay? So you end up at the end of the eminence with the disc in between. If you have an anterior disc displacement with reduction, reduction just means you recapture the disc at the end of the range of motion. So it starts off with the disc in front of the condyle, but as you open, you go click, and might be audible, might not, into the back onto the disc. And so you finish your range of motion with the disc in place, but then when you close again, you come back off of it. Okay? So a lot of people will say, well, you can recapture a disc by putting them in a more anterior position, and maybe you can, but once they seat again, it's very likely that they're going to come back off because those ligaments aren't going to shrink back on their own to hold it back in place. Okay? The anterior disc dislocation without reduction shows that as this person opens, they stay behind the disc. Now, as they mentioned before, sometimes you can still get a good range of motion. You just keep pushing the disc out of the way. And then you end up sitting on the adapted retrodiscal tissue, which is now a pseudodisc. Okay? So some people adapt better than others. Some people adapt more quickly than others. But that's how it typically will happen if they do adapt well. So we already mentioned the hinge and rotation in the inferior compartment versus the gliding and translation in the superior compartment. So that is how that works. So different ways that the disc can be dislocated. So the most common way is for it to come more anterior to the condyle. So what you see here is the disc is, like I said, anterior to the condyle. There's not really any space between the eminence and the condyle there. And the part of the reason is just the pull of muscles and just physiologically the most likely position for the disc to go is anterior. Now, it can go more to the medial, which we see here. The arrows, of course, are pointing towards where the disc is. So it just depends on which ligament got stretched. In this one, obviously, the lateral ligament got stretched, so the disc falls to the medial. This one is a little bit easier to see with it being cadaver versus imaging. Of course, here's the disc there, like I said, anterior. Here's the condyle now. Now, if you notice, the condyle looks more posterior in the fossa. So even if you had a CBCT and you can't see the disc on there, but you can see that the condyle is pushed back, that could, and you just follow other symptoms, that could lead you to think, where's the disc? It's not a guarantee, but you can start thinking those kind of questions, okay? This is more uncommon, but it can happen. The disc is actually posterior to the condyle. So here we see posterior to the condyle, so the condyle is now forward, and there's basically bone on bone there. So it can end up in any direction. This is healthy articular disc. So it's harder to see because we're looking actually from an axial view, basically. So we're looking on top of the disc. So, but you can see it kind of fits the shape of a condyle. But if you can imagine, you see how this is if you kind of imagine the geography of it, it's thinner in the middle. It's a little bit thicker around the sides, okay? Now, this is a disc that was perforated and basically has a lot of scar tissue around the edges. This used to be the main part of the disc. You see the perforations there. There's scar tissue around it as well. So that disc is not going to really help to cushion the condyle very much. Other types of disc disorders can be adhesions. So in this case, this is not an adhesion here. This is just moisture. But you see how there's inferior joint space, superior joint space. This condyle is not up in the fossa. It's kind of down. But see how there's nice smooth lining? This one has adhesions. So adhesions can limit motion of the joint, and they can also lead to discomfort as well when you pull on those adhesions. Now, some people are very big on using Piper classifications or Wilks classifications of joint disorders. I don't typically use either in my clinic, but I just wanted to, in case people do use them, just kind of expose you to what they're meaning by them. The Piper classifications are actually looking at disc position. So in Piper class 1, what you see is the disc is where it's supposed to be, and there's healthy ligaments on the side. That's what those little blue lines are indicating. Okay, so 1 is perfectly healthy. 2, you have some injury to the joint, but it's still in place, and the patient's still functioning pretty well. Okay? A 3 is that the disc is partially out of place, still partly there, still partially out of place. And then, again, there's either with reduction or without reduction. So when you open, do you click back onto it completely, or do you not? And then 4 is it's all the way out of place. Again, can you click onto it or not? So non-reducing is B, with reduction is A. And then 5, they say that there's no disc, so it's bone on bone. So, and then this just kind of goes into more things like, is it early, is it late, are there perforations? You can actually perforate a pseudodisc as well. So that is just more detail to that. Now, another way that people classify the discs are to look at where more symptomology and imaging. Now, this makes it look like it's completely lateral, where if you have multiple episodes of pain, you're also going to have deformity of the disc. And it's not necessarily the case, but it does kind of bring more the symptoms into it. As we mentioned before, or I didn't mention, but in the previous lecture, they mentioned that if you have clicking and popping, but there's no pain, we don't need to do anything. So some of these, they mention more noise, and they make it sound like because there's more noise, this is a progression as to how likely it is that somebody would need surgery. But if somebody is functioning well and not having pain, then they might have noise. They might have other etiology or other physical signs like degenerative changes, but there's not necessarily a need for surgery if they're not having functional problems. Does that make sense? So I don't really use either exactly. I kind of break things down into what's the muscle problem, is there pain, is there inflammation, what's the bone diagnosis, and I'm going to get into that a little bit more, like is it arthritis, is it arthropathy, what's their functionality, can they move well, and then what's the disc doing. So I just kind of break it all down into all the pieces. One thing that we talked a little bit about in previous lecture was occlusal changes. I did want to hit on that just a little bit too. Sometimes if you have somebody come in with occlusal changes, it can be because of bony changes. And I think they mentioned that as well. If the condyle is going through an arthritic process and it's getting shorter, your condyle is going to seat more, which is going to allow you to hit more on your back teeth and then have an anterior open bite. So an anterior open bite might not be the cause of a TMJ disorder. It might be because of a TMJ disorder. Does that make sense? And then also, as I mentioned before, I think it was Tom mentioned that sometimes if there's edema in the joint, it can shift the mandible. But also, if you think about it, if the lateral pterygoid is contracting, it can shift the mandible. So what you tend to have is if my mandible is shifted on the right side, then I'm going to hit first on the left more anteriorly. Does that make sense? So if you kind of take your jaw and pretend like you're a lateral pterygoid, or fire your lateral pterygoid, move your jaw to the left, do you feel how you might hit just a little bit more in the right and the anterior? In the left and the anterior. So sometimes occlusal changes are because of muscle or joint changes. So before making any type of occlusal changes to your patient, you want to make sure that the joint is stable and not painful and that it's not progressively changing, because you don't want to chase occlusal changes with orthodontics or restorations if you don't have stability, because you're just going to keep chasing it. Does that make sense? Okay. Now, the capsule can have, it's basically the fibrous tissue that's around the joint. It can be, part of it is actually the attachment of muscles, part of it's the retrodiscal tissue, but it forms the little bubble that the synovial fluid's in, okay? The lining of it is the synovial membrane. So the synovial membrane produces the synovial fluid, which the synovial fluid then lubricates the joint, reduces friction, lets that disc kind of slip around like it's supposed to. So, and what synovial fluid is basically plasma with hyaluronic acid. So it's actually what supplies the nutrients to the surfaces of the joint, okay? Now, you can have inflammation of the capsule or the synovial membrane. And so it's either capsulitis or synovitis if there's inflammation there. Those can be painful with function, with pressure, things like that. So you might not see anything on the imaging necessarily, but if there's pain to palpation, then that can be the capsulitis or synovitis. Degenerative joint diseases are another possible aspect of a joint pathology. So arthrosis versus arthritis is where I want to go first. So if you have arthrosis or an arthropathy, basically that means you can hear crepitus, you can hear that Rice Krispie sound, you can hear the sandpaper or whatever you want to describe it as, but then you also see changes on the x-ray, on the CBCT, like subchondral cysts, which are little weak spots. They're not fluid-filled cysts like an odontogenic cyst. It's just a weak spot in the bone. You can see erosion of the cortical bone or less density there. You can see more density or generalized sclerosis. It can, either way can happen with inflammation. And then you can see osteophytes sometimes. So you have to call it arthrosis, you have to have noise and one of those imaging descriptions. Arthritis means those same things as arthrosis, plus there's pain. So arthritis lets us know it's actively inflamed. It's actively painful. Now, sometimes that arthritis is actually related to a systemic disorder. So what you notice there is, of course, there's the joint inflammation, there's the bony changes, but that's part of why in the history we ask about, are there other joints that bother you? Are there, because a lot of people don't tell you that unless you ask them. So this is important to know because as they mentioned before, if I'm trying to treat an isolated joint, but my whole body has ankylosing spondylitis, it's going to be harder for me to keep the inflammation down in one place if you've got inflammation raging throughout the rest of your body. So that's where some lab work comes in handy if you do suspect an autoimmune condition or a referral for further evaluation if you don't feel comfortable with the lab work yourself. So these are some images of what arthritis or arthropathy can look like. So basically this image here, you see the condyle's nice and rounded. Fossa is pretty well rounded, so that's pretty normal. But you can either have flattening, you can have sclerotic change, you can have, this one, you can see there's little projections of bone on both the anterior and the posterior. So those are all arthritic changes. Here you see erosion of the cortical plate there. Here, this condyle is shortened, and then it has some beaking in the anterior, but you can see that the normal shape is changed. This one shows you more what subchondral cysts look like. They're those round, less dense areas interspersed with the more dense bone. You can also see erosion of the cortical bone here. You can't follow the cortical border. So that would be a joint with arthropathy, or if it's currently painful, arthritis. Now, I do remember in one of the earlier lectures this morning, someone mentioning idiopathic condylar resorption. So the thing is, idiopathic condylar resorption can look just like arthritis, whether it's osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, idiopathic condylar resorption. So the difference is, with idiopathic condylar resorption, we don't know why it happened. There's not a systemic link. We don't know of a trauma. So it's not a response to trauma that we're aware of. It's just for some reason that condyle is deteriorating and we don't know why. So now you'll hear some patients, they've previously been told that they have ICR or idiopathic condylar resorption, but they also have rheumatoid arthritis. I would beg to differ that they have rheumatoid arthritis in their joint, but there's no reason to complain about that if they're treating it looks the same, okay? So what you would do is, if you look at an image and you see a young child or a young teen with joint changes, arthritis, that's not normal. So I would do blood work. Or if you see somebody that has multiple joints that are painful, you would do blood work. Does that make sense? Just to kind of figure out what else is going on. So this is a joint of someone that has a spondyloarthropathy. So that's like the ankylosing spondylitis, psoriatic arthritis. I forget exactly which one they had. But you see how the condyles, this one, it's hard to make out the border. It's very short. This one, you can see some subchondral cyst. Here, it's hard to make out the border again. So there's a lot of deterioration of those condyles. Idiopathic condylar resorption, this wasn't the best image because she actually looks like hers might have stopped for the time being because she has good cortical bone again. They can look very similar though. But what you can notice here, this really is how her teeth fit together. She was closed. Do you see that there's contact here in the posterior and not anywhere else? And then if you look here, there's contact again there, but not here. And it's because and she used to have good occlusion. She's been through orthodontics. You can even see her mandibular fixed retainer there. They used to touch. Then her condyles deteriorated. Her mandible came back and seated, so now she has an anterior open bite. So that's something to kind of be on the lookout for. This is a second case, same thing. She was diagnosed with idiopathic condylar resorption. You can see how tiny that the condylar head is basically gone there, and this one is pretty much deformed. So these are big impacts on patients. And then that shows you how dolichofacial she is, like see how the condyle has seated into her whole mandible is now rotated down. Okay, so those are some of the problems that you can have within the joint. You could also have a malignant tumor in the TMJ. So this is not something that you're likely going to see very often or at all, hopefully, but it is something to keep in mind. So it can be a metastatic process, or it could be actually coming from the tissue within the joint. So it's something to be aware of if you see something very aggressive, and it might be something that needs to be on your radar to know to look for, to possibly need to biopsy or have somebody biopsy. Pediatric patients can also present with TMJ pseudotumors or tumors. They can present like a regular TMJ disorder, and that can lead to misdiagnosis. So you want to be sure to be aware. If they're not improving, keep looking. This is just basically showing that some cases, although benign, can be locally aggressive as well. So you can have even a hemangioma within the joint space, or a giant cell tumor, or things like that. Some cartilaginous changes as well. So another case for you guys is I had a patient that came in, joint pain bilaterally, mild erosion of the right condyle, moderate arthritis on the left. She had been prescribed steroids and NSAIDs. We ended up doing bilateral Kenalog injections. I'm kind of giving you a shorter history on this one. Pain was relieved. She declined an orthotic. A month later, she returned. She didn't really want to take medications. She didn't really want to do a lot of home care even. She wanted it fixed, but not really do her part, is what I was thinking at one point. And it is true, she didn't want to follow through with things. And so she ended up coming back a month later. Joint's still painful. Range of motion is 39 millimeters, which is okay. Left lateral, though, she can move to the left 11 millimeters, but going towards the right, she can't go more than 6 millimeters. So there's a discrepancy. So a lot of times we want to look for symmetry. So we wanted to do a referral for an MRI at that point, which she declined. 4 months later, she returned. Like, she just would disappear for a while. 4 months later, she returned. Pain was only in the right. We tried oral anti-inflammatories again. I also recommended a sleep study because of symptoms there. Like, her Epworth Sleepiness Scale was an 11, and she woke up with headaches and woke multiple times a night, so all those kind of things. But she disappeared again, and then a month later, she came back. The pain had reduced with anti-inflammatories. She did not have the sleep study. She did not do the MRI yet, but we again were saying we need to do the MRI. I was thinking maybe she'd listen to somebody else. So a lot of my colleagues will, I work with a group of oral surgeons. They don't do surgery on people that don't need surgery, but sometimes just an extra person to look at you and tell you, no, you don't need surgery, you need to do this, is a good thing. So I tried having him come in on a consult. She disappeared again. 2 months later, she finally said, yeah, maybe I need to come in. But she still had not had the MRI. So we did an orthotic. She finally agreed to the MRI. And then these findings basically show in the right, there was not a well-defined articular disc. And then there was a complex fluid collection within the joint space. So it was mixed radiopacities. And she couldn't really do excursives on the right side. The left side, though, appeared pretty normal. So the oral surgeon took a look at it, and he reviewed the MRI himself, and he thought that it looked like pigmented villonodular synovitis or synovial chondromatosis. So basically, she needs to have a joint biopsy. So the pigmented villonodular synovitis is benign, but it can arise from soft tissue within the joint. Synovial chondromatosis is more rare, but it can cause severe joint damage. And her joint had deteriorated since that first CBCT to this point. So this is a learning opportunity for me too. I should have held my guns when I first felt she needed an MRI and had her have it. And like they said earlier, I don't do MRIs on everybody, of course, but if they're not getting better, if things are progressing, if we need to look at it a little bit more, then it gives you a better image of the soft tissue. So for the intra-articular surfaces, diagnosis relies on thorough history, as they mentioned. Like Tom mentioned, sometimes if you ask the patient what you think is going on or have them show you exactly where it is, that gets you a long way. Patients know more than we give them credit for a lot of times. They can point us in a good direction. Look for comorbidities. That can help you to determine if you're treating one joint or if you need to have somebody else treat the whole body. And then with the joints, I do use a stethoscope to listen because I can pick up crepitus better that way, me personally. But my kids tell me I'm getting hard of hearing already, so, who knows. But I hear better with a stethoscope. So I'll do that, palpation, evaluate the range of motion. That gives you a big hint as to what's going on. And then other tests can include radiographs, MRI if needed, blood work if needed. So the history kind of gives you an idea of which direction to go in. But overall, I threw in a couple of cases on both the muscles and the joint that you're likely not going to see, but the reason I did that is just if things aren't going as you predict, step back and look and see maybe something else is going on. Okay? So I think that is the end of what I had. I know we were going to do, what time was the question answer session? 11:55. You're cruising. You're doing great. Well, I actually cruised a little too fast then. Wow. So if y'all want, I know Sherwin's not back, but we could start taking questions, or we could see if we can find Sherwin, or what do you think?
You know, I don't know what, was Mariana intending for all three of us to be?
She intended for all three of us to be a panel at the end for them to fire questions at.
I'd suggest to take an 8-minute break, and if Sherwin's here, then we'll go, and if he's not, then we'll do it without him.
Okay. Does that work for y'all? Okay. Sounds good to me. Unless y'all have a quick question that you wanted to fire right now. Either way is fine. Oh, yeah. Let me pull that. So, to tell you the truth, I don't think it necessarily is something that you have to worry that much about, because the treatment is still going to be to try to reduce inflammation. But technically, capsulitis is pain of the ligaments and the supporting structure of the joint. A lot of times you can feel that more with movement of the joint, things like that. Synovitis is the inflammation of the actual lining of that. So a lot of times if one's inflamed, the other's inflamed too. So I don't find it myself, and I'll let Tom answer differently if he feels, I don't feel it is that critical to differentiate that closely, because either one, if you palpate here, you're palpating both the synovial membrane and the capsule. So it makes it kind of hard, but that's technically the difference.
That's why they're trying to just create the diagnosis of arthralgia rather than
Right. Well, arthralgia, she asked, is that why we say arthralgia rather than specify that? Well, you can have arthralgia, which technically just means joint pain, if it's arthritic condition or if it's just the soft tissue. So I think there still is arthralgia is a symptom, but it doesn't really tell you if there's inflammation of the bone, is there inflammation of the soft tissue, is there the disc got a place and you're impinging on the retrodiscal tissue. So you still want to kind of figure out for your own use to try to figure out how best to treat it, which of those things might be contributing. Does that make sense? Okay. Anybody else? Yes.
You have a patient with osteoarthritis, and you want to know if the process is active. Do you use some studies like radiogram or SPECT?
If I have a patient with arthritis and I want to see if it's, if I want to see, so if there's pain there, then I think there's inflammation there. If it's pain-free, and then it might not have inflammation, but it might still be deteriorating. Sometimes people with like idiopathic condylar resorption, some have pain, some don't. You can look to see if the cortical bone looks like it's intact, because if the cortical bone's intact, then sometimes they're adapting at that location. There are images such as there are images that can, but the studies don't show consistently that they're very predictive of the progression. So putting somebody through expensive imaging with radioactive uptake is not necessarily going to tell you is the ICR or the arthritis going to go forward or not. A lot of times, if it's painful and it feels like there's active change, you treat that. If it looks like everything's stable and they're having no pain, if you put something like I oftentimes will use a orthotic or a splint, and if the bite doesn't change on that, then that helps you to know that the joint is stable. If the bite keeps changing on that, then you know something's progressing.
How long do you want for?
I would wait about a year of stability. for something like that. I may be going I've seen some people do 6 months, but it's got to be time. Would you say?
You know, if you're thinking of arthrosis, was that your question, sir?
Okay, we know the process is active.
Yeah.
Sometimes.
Yeah, you know, so when I think of the term arthrosis, I think of it according to like the TMJ's diagnostic criteria. So if you have arthrosis, you've got degenerative changes, but you don't have pain. You don't have arthralgia, right? And you know, it's really common to see people who have some degree of degenerative changes, right? If you look at Panos, you're going to see all kinds of people who have flattened condyles or osteophytes or maybe some condylar asymmetry. Rarely is it so advanced that you actually, at least in my experience, that you actually see occlusal changes. If it's so bad that you're seeing occlusal discrepancies, then there's probably something more aggressive going on than just run-of-the-mill DJD. You know, they probably have, like Mary Charles mentioned, ICR, right? Idiopathic condylar resorption. I don't know, did you guys get into that much?
We did. We
Yeah,
talked about it.
I mean, young females, right? Or, you know, if it's an arthritis that's so bad the occlusion's changing, I start to think, you know, is there a systemic arthritis underlying this? Does this person have rheumatoid arthritis or Sjogren's or systemic sclerosis or, you know, any of that whole spectrum, that whole host of autoimmune conditions? If it's arthrosis, if you're seeing some evidence of degeneration, if you're seeing crepitus, but the person's not in pain and they're functioning just fine, and you don't see some occlusal discrepancies, frankly, I wouldn't worry about it. I would just reassure them, if they have some concern about it, that, you know, as long as there's no pain, no dysfunction, and you don't feel like your fight's changing, I'm probably not going to monitor that for change. I don't know, did you feel differently about that?
No, I thought he was asking about one of the more degenerative diseases, and before trying to, like the systemic arthritis, things like that. That's where I was saying that once you want to see if if you've kind of brought in, say, a rheumatologist or people like that, and you want to make sure that the joint's not still deteriorating, that's when I would be monitoring for continuation of changes.
I mean, you know, if it's that kind of a situation where you're monitoring ICR, Mary Charles might have mentioned this too. You know, you can do, and I don't think I've ever actually done this, but you can, you know, in the case where you think it's stabilized, you could order radionuclide imaging, you know, and see, you know, of course, it's a non-specific marker. It's not going to tell you what's happening. It'll just show you that there's excessive metabolic activity in, say, condyles, right? Another thing you can use as a monitoring tool is you can use an occlusal appliance. You know, and the patient doesn't even necessarily have to wear it, but they can put it in and you can adjust it so you get nice, even bilateral anterior, posterior contact. And you just make sure you make a note of what position they're in, like maybe you have the cantotrigal line perpendicular to the floor. So that when you see the person back in a few months, you can put it back in and mark it again. And just see, okay, where are my contacts now? And do I still hit nice and even anterior, posterior, or are those contacts in the front starting to disappear? You know, which would suggest, in that case, something like a bilateral, you know, progressive condylar resorption. If you ask oral surgeons about this, a lot of the surgeons in cases of ICR are going to, and maybe you could say, well, the surgeons you work with favor. A lot of surgeons seem to be favoring total joint replacement for these cases. And that, I think, comes down to a matter of really patient education, right? What are your options, either surgically or non-surgically? You know, in a case like that, the real bummer is if you put somebody through, say, you think it's nice and stable, the joint's not changing anymore, and then they go through orthodontic treatment and orthodontic surgery, and then afterward, the bite opens up again, that's a real bummer. Mm-hmm. So if you do the total joint replacement, that will stop it, you know, but of course that's pretty invasive too. And, you know, do we really know how long our current prostheses last? I don't think I know. I mean, the current ones that are on the market. If this is a young lady with ICR, she's going to have to get 70 years out of a prosthetic joint. That's a long way to go. So I think if it's a case like that where you have progressive resorption, it's really making sure you have an open and detailed discussion between the patient and yourself and the oral surgeon, and give them the best information they have, because it may be a matter of choosing between two options that both have some substantial potential complications in the future. Maybe I got into the weeds on that a little bit, but do you have any, how do you guys handle ICR with the surgical practice that you're in?
Well, that's what I thought he was asking about before, and yeah, and I told him that, kind of almost opposite of what you said with the radio nucleotide imaging. I've heard that sometimes it's not very predictive as to future progression, so it might look stable at this time and then amp up again. So I told him that sometimes that doesn't really tell you the long term. But I did tell them the same thing about monitoring with the occlusal orthotic or the splint to see how the stability is there. I would tell you with the surgeons that I work with, they're, as I said before, they're not going to jump to surgery, which is part of why I'm on their team, because I'm kind of the person that helps to take care of these patients that aren't surgical. But they have done, and they do total joint replacement in those very severe cases. But as Tom mentioned, you don't know for sure if they're going to need another one somewhere down the line as well. So, I mean, I would agree.
It's a tough situation.
Do you guys want to come up here? 'Cause,
Love to come up there, especially if Sherwin's going up there.
yeah. I was going to let y'all. So if anybody else has.
Well, we can flank you. We'll be your bodyguards.
Okay.
What is the prevalence of the degenerative cases that you're discussing, like per 100,000 population?
I don't know. I couldn't quote them. Do you know what the epidemiology of ICR is?
Oh man,
I mean, I don't know what it is. I will tell you, I've seen more of it than I thought I would. And that's not a ton of cases, but it's a handful that I've run across over the years. I think since I've been at my current duty station, I might have mentioned Eglin Air Force Base, about 6.5 miles west, or 6.5 hours west of here. I've seen probably 3 cases of idiopathic condylar resorption, so that's a case a year. My population tends to be younger and a little more heavily male, just because it's a military setting. But so it probably doesn't reflect a normal community population.
Right.
But you know, it's not by any means crazy that you'll see these cases. They're definitely out there.
I have to say, I don't know the numbers either. And again, since the focus of my practice is just orofacial pain, I probably would see more than you would in your regular practice because they're being referred in. But yeah, like he said, they're out there. And I've seen more that aren't true ICR. They're more autoimmune triggered in a lot of the patients that I've seen. But I've seen both. So.
yeah, with ICR, we have also, I would say, a handful, probably 5, 6 cases, and I'll call these very textbook ICR, where you don't have any inflammatory factors. You know, when you do blood work, there's nothing. It's going to be a female from the age of 13, 14. It will just continue until the early 20s. A lot of ways to manage it. The most common is to monitor it, do annual CBCTs, and wait till it burns out. Some people like to do surgery. Again, the jury's out on that. Not much has been proven to stop it. It usually stops, well, it always stops by the time it reaches the neck of the condyle. Some people claim that you can, or nighttime appliances or daytime appliances won't do anything. Putting a steroid in the joint won't do anything. There's no proof that anything does anything. You just have to wait till it stops, or there are a couple surgeons in the country that report, and it's always the same couple surgeons that report that they can just cut off the condyle at the neck and do joint replacements.
At least it's reassuring it won't go past the neck.
Yeah,
I mean, your whole
exactly.
jaw won't disappear, so
Right.
count your blessings, I guess.
Right, so the question. Yes, some authors mention TMJ condylar rotation and translation occur at the same time through EMG studies. Show that there's no pure rotation or pure translation. It's an interesting point. I think that when you look at the dynamic nature of how the joint moves, And in one patient, you might have a little bit more of an adhesion of the disc to, or I should say, a little bit more contact with the fossa. So maybe in these cases, they just happen to get patients that really have concurrent movement. In other cases, you may not. I don't think it matters much one way or another. I'm kind of curious from your perspective, whoever asked this, how do you think this would alter anything clinically, more than anything like that? Yeah. I mean, from a clinical perspective, whether you have a rotation and a translation, or you have, rotation and then translation, if somebody has limited opening, I can totally see a case where you would go in and do a one-needle arthrocentesis, really just like pump it with full of fluid, manipulate the mandible to get it moving. Again, I'm always trying to relate something like this with a clinical finding with no other pathology or anything like that. I don't think it would make much of a difference otherwise.
I would add, as I think the point of us saying that is more which portion, whether it's below the disc or above the disc, where it's moving. But yes, you can, as you're opening, both can be happening. You can be translating, and so you're moving under the disc and the disc moving with the translation. So it's not necessarily that you have. I don't think I don't think it's necessarily, like you said, that very important as to which happens first and if it's at the exact same time. It's more, this is happening below the disc, this is happening above the disc, and kind of they're both helping you open.
Yeah, I think it was from my lecture, I think, because, from the textbooks, you start out with the rotation, 20 millimeter, then, so it's happening, this, then that.
Yeah.
So I think that's where we're going. You have the rotation happening in the inferior portion of the disc, and you have the translation, of course, superior. And I think a lot of that will have to do with just the intra-articular pressure, kind of holding the disc up to the temporal bone. But again, practically, it would be more of a range of motion aspect, whether you can get the patient open with either physical therapy, procedure, sometimes even you got to get in with a arthroscopy to kind of get the disc moving. But overall, I don't think it would change much. Yeah.
Just making a move for the mic here. Yeah. Have you guys ever seen the YouTube videos, the famous temporomandibular yoint videos? Yeah, did you watch those? Those are great videos. If you haven't seen those yet, I suggest go to YouTube and look it up. Just Google, just search for temporomandibular joint, the yoint video. The yoint thing comes from, it's a couple of Danish guys, I think like back in the 80s, that made this video, and so they say it's a temporomandibular yoint, a time or two. But you pull it open, and they've done these terrific sagittal cadaver dissections that show you, muscle, joint, disc movement. And of course, it's somewhat artificial because somebody's manipulating that mandible. You don't have the masticatory muscles moving of their own accord. At least I really hope not. But that really gives you a fascinating, visual of these tissues moving. And yeah, I think it totally makes sense. You got rotation and translation. They're happening together to some degree. So this is an issue where the translation and the rotation can come together. It doesn't have to be Apple versus Samsung or red versus blue. We come together on this one, guys. Rotation and translation united, stronger united.
I think that the point that Sherwin made about if, though, you can only open to, say, 20 millimeters, then you gather that the translation part's not happening.
Right. Yeah. Right. So you got to get that disc moving somehow. Yeah.
Anybody else? Yeah.
Are there some components, hormonal components in the
Yeah. Estradiol. That's one thing that I used to see it a lot in some of the literature, maybe from a decade ago. Hasn't really been proven. I haven't seen it really go anywhere to change treatment. I don't know if any of you have heard of any way that anybody's being treated. You're right about that. I think it was 17 beta estradiol or one of these hormones. But and it was one avenue where it was being looked at was in terms of birth control. In terms of is someone perhaps using it or they should use it, but it hasn't really changed treatment today. Yeah. Yeah, there are no markers that we know of reliably that can help diagnosis of ICR. And it's interesting. With ICR, I do want to add this. It's interesting because the whole condyle just gets kind of smaller. So even when you look at it radiographically and you compare it to an arthritic joint, even somebody who has a systemic arthritic disease, where it would be bilateral because it's systemic as opposed to a unilateral joint, within rheumatoid arthritis, the articulating surface is going to be flattened, and it's going to get worse, and it's going to be very irregular. With ICR, you don't necessarily have that. And in fact, you don't even have diminished joint space. It actually sometimes is larger. You have hyperplastic tissue in there, actually. So it has very different clinical characteristics that where you can differentiate it to, even radiographically.
Alan?
I guess I would say there's a relative change in incidence or prevalence that we're getting referred from the medical community with regular condition. Not coming in, but specialty can be seasonal. Do you guys see that rheumatology is actually sending more cases your way?
Over at even at the UCLA, we're well aligned with we're well connected to the medical center. On the outside, I don't think that it was some magical event that when specialty status happened, all of a sudden everybody knew. So I don't think that on the outside it's that case, it's like that. I still think it has to do with the providers that are now in the wild marketing to the providers. It still is going to be the same. That's my thought. Yeah, I don't think anything magically happened.
Yeah, I would kind of agree. It's more, I know that there's a pediatric rheumatologist that will send me patients, but it's more because I've also sent her patients, and so we have a connection there, so she knows if somebody's having symptoms in the joint, the temporomandibular joint, then I can help with that. And just like I know if they have a systemic condition, I want her to help.
For the Sunday morning, there will be the pediatric rheumatologist giving the presentation on this specific issue. When she's from the University of Minnesota, and definitely works with the providers, the local providers, trying to learn from them, some of that case reviews together. So I think the awareness is great with the physician paper, review paper, and technology that came up, not too long ago. Yeah, more aware.
We had a question over here.
I'm hoping you guys could talk a little bit more about disc perforation, diagnosis, and treatment.
Yeah, really the gold standard for diagnosis is still MRI. I know that you can also get in there with some dye and also see if you have a perforation, but still MRI is the usual way you would do it. As far as how you would treat it, it would still be clinical. Because remember, even if you're bone on bone and your disc is gone for all intents and purposes, you still treat the patient clinically as long as there's no secondary condition going on. So a perforation to me is still a perforation. It doesn't really, that by itself doesn't change my treatment.
Yeah, I agree with that. I even think, and you guys can share a different opinion if you have it. I'm not sure you would always see a perforation even on an MRI. I mean, there's some things that you just miss. It's hard to see perforations. I think it's hard to see fibrous adhesions. I think those sometimes you can catch them on an MRI. Sometimes you just don't. So probably to really find a perforation, if you don't see one in imaging, you're going to be doing arthroscopy. But that's a rare skill set and kind of a rare set of equipment. Most oral surgeons, even those that do a lot of arthrocentesis, probably don't do arthroscopy. And it's one of those things, where you wonder if the juice is really worth the squeeze, because whether it's perfed or not, the treatment's probably going to be really essentially the same.
Yeah, the real gold standard, I should have said, the most common way of diagnosing it is MRI, most common way. It's really arthrography, like I said, with the dye. I mean, you'll see it that way. But I don't know anybody who has actually ever done it, because I don't think it changes.
It's kind of gone out of phase.
It's gone out of phase.
Right?
That's,
I
yeah.
don't think hardly any radiologists do that anymore.
Yeah.
But like they mentioned too, arthroscopy is another potential change. But if they're not having pain and if they're function and they're able to open well, then whether there's a perf there or not is kind of not important at this point.
Yeah, it's not going to change anything. Sometimes the joint that looks best is the one that hurts most. So and the other joint could look absolutely awful. So perforation, like I said, by itself wouldn't change anything.
And I mean, I'm going to just guess. If I was a gambling man, I'd wager that if you dissected a whole bunch of joints, you'd probably find a lot of disc perforations in pain-free individuals. Mm-hmm. And that doesn't mean the perforation isn't contributing to the pain in a given person. It might be, but it's just one of those where you can't draw a straight connection between pain and perforation. Kind of like imaging findings, right? Imaging findings don't correlate well with symptoms either. I mean, you might get an indication on MRI of whether, or on CT of whether hard tissue is still undergoing active degenerative changes, but those tend not to correlate well with symptoms. Like Sherwin just said, even radiographically, a nasty looking chewed up joint or degenerated joint might be doing okay, and the joint that looks nice and round and perfect might be in a lot of pain. So
Yeah.
it would be nice if things were more straightforward, but they're just not.
Yeah, I mean, the whole thing is, what would you even do? You would have an oral surgeon do a discectomy. Now you're running it. Now that's worse. But they're going to take out the disc and put abdominal fat in its place. Patient will have then fibrotic changes, neuropathic pain, scar. So you wouldn't do anything anyway. There are very few cases where you'd really go in there. Synovial chondromatosis, if it's changing and symptomatic. Something, of course, some sort of metastasis, if someone has that. But there are very few cases where you actually want the joint opened up anyway.
I mean, yeah, the open joint surgeries, my understanding is you can do okay at fixing, physical, anatomical problems or obstructions with a procedure. But pain is a lot more of a grab bag. Are you going to actually improve the pain, or are you going to make it worse? That's where you're rolling the dice with an open joint surgery.
They'll probably talk more about neuropathic pain later, but what they're getting into is if there's a chronic pain situation, then just fixing the physical is not necessarily going to take the pain away. So,
Yeah, so you got a patient with a perfed disc, and let's say it is perfed, and now the patient didn't have pain, and now they're going to end up with pain. I'd be more equally as worried about a facial nerve damage. That's what can happen with this specifically. So definitely by itself, I don't care. Yeah.
any other questions? Well,
I know that we all know that so many of these patients have, multiple defects in plethora of things that can contribute to their problems. But if you see somebody that's been posturing themselves in an irregular way and develops slight changes that have later been modified, say, by orthodontics, how do you help them find their bite again, apart from stabilization and science? Because I have a patient that has 2 bites. She's had improvement totally wrong.
Yeah. I think that's kind of a loaded question, but I'll answer it. The current. Yeah, so it's about a patient who's had occlusal changes through what form? Was it equilibration?
She used to posture her mandibles to show more of her lower
Yeah.
teeth because she thought it was more attractive.
Like protruding?
Yeah.
Yeah,
Yeah.
so
She's
Yeah.
class 2.
laxity, and now she can't really find her MIP is very different from where her center relation is.
So the current consensus, as you know, is that bite does not correlate with as a cause-effect association with TMD. So if somebody came to me and had that change, I wouldn't necessarily want to now change it back. So in terms of the bite. But what symptoms, so I would still look at her, what symptoms is she having though? Symptoms.
Well, she is having joint pain.
Okay.
And part of the problem too, I think, is she's having excessive mandibular movements because she's having a hard time finding this comfortable movement.
occlusal
And I know she's not
dissociation.
supposed to put teeth together, but when she's chewing, it's a tricky case because orthodontically she's had several treatments. And I don't know why, but the orthodontist is now really altered her.
Does she have bilateral contact? Does it look good to you? Does she have, is it even contact?
So she has an open bite,
Yeah.
like in the back?
Right,
Huh.
and laxity. You know, an open anterior bite.
Open
Yeah,
anterior
so she has
bite.
posterior occlusion.
This might be something
No, yeah, I would treat it, I would treat it, I mean, there's so many courses here. I would treat it like a TMD case, how I normally would. PT, injections, change of habit, that's the big one, I should start there. And if she's constantly checking her bite because it bugs her, no joke, pain psychology, cognitive behavioral therapy, sometimes even biofeedback. That because remember, if somebody comes to you with a mild open bite, anterior open bite, that in and of itself, I would never send somebody for ortho to address a concurrent temporomandibular issue. So again, that wouldn't change anything to me. But if she wants to have braces again or Invisalign, I'd say go for it to close your open bite, but don't correlate it with any of your symptoms whatsoever. So,
I would also add maybe investigating whether it's more muscular pain, joint pain, where is the pain coming from so that you can tailor the treatments towards what is actually causing it. And then instead of, because I know we use the term like TMJ pain, but there's so many different things that it could be. Trying to narrow it down would help with the treatment as well. And just have the occlusion as a separate thing.
exactly. That's exactly what I would do. Yeah.
Anybody else?
Okay.
Okay.
Thank you to all the speakers.
Thank you. Thank you. Thank you.